The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.
While the world may currently be focused on the COVID-19 pandemic, the fight to tame another devastating epidemic has been underway for nearly 4 decades. And so, on this World AIDS Day, for the full hour, we're examining that. First, we'll track the progress of science towards a vaccine and a cure. Then we'll find out how communities across Canada are coping with rising infection rates and what can be done to stop the spread of HIV and AIDS. It's Tuesday, December 1st, and that's next on the agenda. When AIDS, or acquired immunodeficiency syndrome, first emerged 40 years ago, it was a mystery to doctors and researchers. Since then, it's killed more than 30 million people worldwide. The pace of that carnage has thankfully slowed, but HIV, or the human immunodeficiency virus that causes AIDS, is still out there, infecting another million-plus people every year globally. With us to help understand the progress that's been made to deal with it, we welcome, in Burlington, Ontario, Dr. Charu Kaushik. She is an HIV researcher and immunologist at the McMaster Immunology Research Centre and a scientific director at the Canadian Institutes of Health Research. And in the downtown core of Ontario's capital city, Dr. Rupert Call, Director of the Division of Infectious Diseases at the University Health Network and the University of Toronto. And we're very pleased that the two of you could join us on this important day on our annual calendar. I want to just start by taking a few seconds here and going through a bit of a fact file of red letter dates that have got us to this day. And we're going to start nearly 40 years ago, 1981, where the world first became aware that the rare immune deficiency disease among gay men and eventually injection drug users, AIDS, became first known. The year later, 1982, the disease is actually named acquired immune deficiency syndrome and is sexually transmitted or by blood transfusion by the human immunodeficiency virus HIV. And Canada, in that year, reports its first case. Fast forward to 1990, the antiretroviral drug AZT as they called it in the States, is approved for use in Canada. In 2005, point-of-care testing becomes available. Patients can get HIV test results in 2 minutes. In 2011, news of the so-called Berlin patient, Timothy Ray Brown, is the first person cured of HIV. In 2016, HIV preventative drug pre-exposure prophylaxis, or PrEP for short, for individuals at high risk for HIV infection, that's approved for use in Canada. It's a bit like the birth control pill. You take it every day and it's 99% effective. And we should mention that there are currently 63,000 Canadians today living with HIV. Now, let's start with this. As we suggested, it's been almost 40 years since we have become aware of this disease. A tremendous amount of money and research and efforts by the scientific community has been undertaken, and yet there is still no cure, there is still no vaccine. Dr. Kaushik, start us off here. Why has this disease proved to be so formidable?
So thank you, first of all, for having me on this program. And then in answer to your question, there's multiple reasons. Probably at the top of the list would be the nature of this virus. It's probably one of the most mutating virus. In fact, the virus mutates inside every person once it gets in. So it's proved to be very difficult because the part of the virus to which we need to get the immune system to respond to kill the virus or deal with the virus is constantly changing. So it's very hard then to pin down what would it take to get a vaccine that actually looks and is able to neutralize all of the different types of viruses and the surfaces of the virus. So that's the problem with the vaccine.
Dr. Call, what would you add to that? And maybe I can suggest the following. Do you think there's been an adequate commitment by all of the world's resources in order to try to keep up with this disease and virus?
It's hard to. I mean, I think Dr. Kaushik said, completely right. one of the challenges that I always say to my patients when they're saying, why don't we have a vaccine yet, is it's when you look at the history of vaccines, it's always hard to make a vaccine against an infection that we don't naturally make immunity to. So HIV is quite different to many other infections where a small number of people may get a bad outcome, but many people who get that infection clear it and eventually wind up with immunity. HIV obviously is one of these infections where natural clearance of the virus and natural immunity does not appear to happen. And I think that just says right up front that there's a biological barrier to making a vaccine, that it's going to be that much harder to make a vaccine. So, I think that we have had considerable resources put into HIV vaccine research in the past, nowhere near the amount that's been put into the COVID vaccine, for instance. I'm always pushing and advocating for more resources, but it has been a challenge, and I understand that it's hard to maintain the enthusiasm when it's taken so long to make a vaccine successfully.
No, I take your point, but can you follow up with this? This is still a difficult disease to get, is it not?
So HIV the research that I do in the lab is looking at HIV transmission. And HIV is quite fascinating in the sense that most of the time when you're exposed to HIV, sexually, you don't acquire it. It's less than 1% of the times that you're actually exposed that you do acquire it. And so one thing that's very interesting is trying to understand what are the correlates of transmission of that virus. It's quite different to exposure to many other infections that we look at in the in microbiology and infectious disease.
Right. Dr. Kaushik, how about this? We did suggest earlier that Timothy Ray Brown and another patient from England were cured, which, doesn't seem possible. How did that happen?
So these were sort of unique cases. Before the London patient, the Berlin patient, or Timothy Ray Brown, was the only known person who was known to be cured of the disease. And it happened a little bit because of serendipity, because we didn't actually know that this was going to happen, but he also had cancers. And when they did a bone marrow transplant to deal with the cancer, knowing that he had HIV, they put in bone marrow cells that from a person who didn't have CCR5. So CCR5 is one of the molecules that cells need to express on their surface for HIV to get in. So without this co-receptor, the virus cannot get in and cannot replicate. We don't understand all the nuances of why that would happen, because at that point the virus would already have been in his body. But the fact of the matter is that after that, there was no more virus replication in both these patients, which had exactly same treatments. It doesn't happen with everybody, but it certainly happened in these two cases, that the virus could not be found anymore and wasn't able to replicate.
So, Dr. Kaushik, as opposed to leading or ushering in a whole new era of lots of people being cured, that was really, it wasn't applicable going down the road. Is that right?
Well, it's not applicable because it didn't work in everybody, and also because bone marrow transplant is a very challenging procedure in itself. It has lots of challenges, and people have to be immunosuppressed. So it's not scalable in terms of applying that to millions of people.
Now, I've heard this expression, Dr. Call, that some people who live with HIV are, quote unquote, functionally cured. What does that mean exactly?
So I think there are lots of nuances and semantics when you get into HIV cure, right? And so usually we talk about two types of HIV cure. We talk about a sterilizing HIV cure. If I have a sterilizing cure, that means my body now no longer contains any virus that could cause disease for me, that could be transmitted to somebody, or that can replicate. And then a functional cure means that I have virus still in my body that is able to replicate, but I'm controlling it usually without the use of medications. And so I think it's really important to point out that when we are looking at people who acquire HIV naturally, about 1 in 200 people, 0.5%-ish, are what we would call an elite controller. And that is somebody who's able to maintain the level of virus down at undetectable levels, which is our goal when we are treating HIV infection with medications. They're able to maintain it at that level without medications. And so to some degree, that is already a functional cure that we see in about 1 in 200 people living with HIV. Now, that doesn't tend to be permanent, and we know that those people do almost all have replication competent virus in their bodies. And eventually, we tend to see disease progression in most people. But there is a substantial number of people, and there's very interesting research going on looking at correlates of that HIV functional cure without medications.
Now, having said that, Dr. Kaushik, let's go back 30 years. The introduction of retrovirals, that was an absolute game changer in people, for people who were living with AIDS. How so?
So before that, I do this in my immunology 101 class when I'm talking about HIV. If you look at the graphs that show how many people were dying, it was tens of thousands of people that were dying. It was basically a death sentence. And then early on, where there was promise of antiretrovirals, then one retroviral at a time was tried, which basically stops HIV from replicating inside the body. And that didn't seem to work because the virus, as we talked about, we didn't know at that time in early 1990s, the virus would mutate and people would actually be sick with virus that couldn't be treated with the antiretrovirals. So then the outcome of that was that at least 3 different antiretrovirals were put together so that there was no way for the virus to get out of that in terms of the 3 antiretrovirals working together. And with that combination, the virus could no longer replicate. And that was a game changer. Because after that, within weeks and, pretty much everybody within a year controls the virus level to a point where it's undetectable.
And again, 30...
That has led to the HIV becoming a long-term chronic infection rather than a death sentence.
Understood. And again, going back 30 years ago, Dr. Kaul, what kind of side effects would a patient on retrovirals be looking like at that time?
So these regimens, when they came out, again, Dr. Kaushik is completely right. At first, we were using just the one medication, AZT. I think that was on your timeline there, Stephen, at the beginning, 1990. So when I was doing my training, which was back in the 90s, we were sort of adding one medication after another, and people would still progress eventually and develop disease and die of AIDS. The reason why we were adding them one at a time was these medications were quite toxic. And AZT can suppress the bone marrow. AZT can change the fat distribution in your body. AZT has a number of toxic effects. And the other medications that we were using early did too. So we had this mixture of quite toxic medications that also, some of them had to be taken with food, some of them had to be taken certain times of the day. So it was a very complicated regimen, those early regimens that we were using.
And Dr. Kaul, compare it to today. How do you treat differently today from back then?
So today, we still have the same broad principle, which is that most of the time we are combining medications together, 3, sometimes 2, but usually 3 medications together. But those things now have much less in the way of side effects as medications, and they can be co-formulated together and taken just once a day. So most of the time, when I have a new patient in the clinic, I'm able to start that person on 1 pill a day and maintain that person with just that 1 pill a day for the rest of their lives, which will be a fairly normal lifespan, and which will be, I think, very different to the life that would have been lived by somebody living with HIV 20 or 30 years ago, in the sense that people have, there's even some very interesting model that suggests that if I'm diagnosed with HIV today and start on medications, my life expectancy may be increased. I don't know that I completely believe this, but maybe increased above that of me without HIV, because not only do I have excellent medication, which is able to suppress the virus very well, but I'm going to be seeing the doctor more often, so perhaps I get other health care that has health benefits and is able to prolong my life as well. I don't know that life will be longer, but I certainly think that life expectancy will be almost the same, and there's much less in the way of stigma in the sense of the transmission to my unborn child is going to be minimized with the current regimen. Transmission to my partner is really prevented completely with current treatment. So that same treatment, if I am able to bring down the virus level to undetectable, that is going to prevent transmission to my partner, to the point that Justice Canada announced a few years ago that they no longer recommend prosecuting cases where patients do not, where a person living with HIV on treatment does not disclose their HIV status to their partner, because there is no realistic chance of transmission. And so clearly the stigma and the barriers that are faced by people living with HIV are much less than they used to be, although they are still substantial.
Well, let me follow up with you on this, because we talked again in the timeline at the beginning about PrEP, which is a preventative form of medication and treatment. How exactly does that work?
So PrEP is a simplified version of the same regimens that we use for treatment. So generally the treatment that we give will be 3 medications. PrEP is often 2 medications given together in one tablet called Truvada, was the original PrEP. And essentially, usually we give PrEP continuously. So every day I take one of those pills every day. And if I'm able to do that, that reduces my risk of acquiring HIV if I'm exposed, not to 0, but 95% plus reduction in my risk of acquiring HIV. And actually coming down the pipeline probably in a few years will be even better regimens. There's some very nice data coming out at the latest World AIDS Conference that an injectable medication given just once every couple of months is even more effective than that daily pill. So I think that the way that we prevent and treat HIV, we have injectable treatments coming as well, is going to change quite a bit over the next few years.
Dr. Kaushik, I have to ask you this next question, which is, you know, the world knows a lot more about vaccines and diseases and viruses thanks to COVID-19. It is almost all we've been talking about for the last 9 months. And yet here, you know, the AIDS community has been at this for 40 years. And it looks like we're going to have a vaccine to COVID-19, you know, potentially within a year of its arriving on the scene. And 40 years later, you still don't have one for HIV or AIDS. And I guess I need to know how annoying that is for you.
Well, so, you know, I'm sure everybody's heard Dr. Fauci on television, because he's also an HIV vaccine researcher, you know, and you hear for 9 months, most of us who've been, you know, in the area of HIV vaccine and following that progress very closely, you know, we're very worried about how likely is it that a new virus you know, could be dealt with in a form of a potent vaccine, and at best, and even WHO, you know, for COVID-19 said if it's 50% efficacious, we'll take it, considering, you know, the level of death that's occurring around the planet. So I'm delighted. You know, I always say to people that if it were a pandemic flu, which we were quite prepared for, in fact, H1N1 we dealt with, you know, very well, because flu vaccines, we know exactly how to make them, and it was made, and within months we got rid of H1N1. This was a new virus that we didn't know anything about, and given the possibility that it's an RNA virus, it could have gone the way of HIV, which is also an RNA virus, and very difficult to formulate a vaccine against. But fortunately, we have gone the way of the flu rather than the HIV vaccine. So I'm happy that at least we won't be living in a pandemic for years and years. But on the other hand, you know, there are lessons to be learned. I have to say that the COVID vaccine, one of the reasons for its success is how much more we understand about vaccines based on HIV vaccine and its failures in last 30 years. So a lot of those lessons were carried into the COVID-19 vaccines, but now we can flip it around and see how much we can learn from COVID-19 vaccines to take the field of HIV vaccine forward.
I do need to ask Dr. Kaul a difficult and uncomfortable follow-up question, which is, you know, anybody can get COVID. If you talk to somebody and, you know, the aerosol droplets are there, you can catch COVID that way. For a long time, particularly in the 1980s, there was a strain of thought which said, you're not going to get AIDS unless you're gay or you use intravenous drugs. And it was a way of saying, this is a disease that happens to them, but not to me. And I wonder if that is part of the reason why 40 years later, you're still looking for a cure.
You know, clearly there's been a lot of stigma against HIV, and I think there's a lot of stigma against any infectious diseases. When you look at TB, when you look at COVID, you know, the stigma against any of these infections. And we do see clear differentials in the incidence of infection in different communities around Canada. And whenever we have something like that, that can lead to stigma for any infection. I always love the fact that, you know, when you see somebody who is having a baby, you say, oh, congratulations on becoming pregnant, which clearly involves having unprotected sex. And when you see somebody who's acquired HIV, you stigmatize them and say, well, this must mean that you're in some way immoral. I think that this is just one of the fallacies that's out there about HIV. But I do think that there are clear biological challenges to an HIV vaccine that we're realizing are not the same for a COVID vaccine. So I really think that it's a much more difficult vaccine to make. In many ways, I love the fact that we've been so successful with the COVID vaccine. I think it's probably going to boost interest in vaccines for many infections. And I do think that the technology that's been used for the first couple of vaccines, at least, the Pfizer and the Moderna vaccines, it's going to be very interesting to apply that mRNA technique potentially to an HIV vaccine. And I think it'll be interesting to see if that could, in some ways, bypass some of the barriers that we've had to HIV vaccines. And I'm sure there are clever people out there already trying that technique for an HIV vaccine.
In which case, Dr. Kaushik, how close are you to a vaccine for HIV or AIDS?
So there's a number of new areas that are being explored for new initiatives into HIV vaccine. One of the very promising areas is to, because we've learned from the lessons of previous vaccines what doesn't work, is to actually try to formulate what are called mosaic vaccines. Where you don't take just one type of HIV vaccine, you take multiple parts of multiple types of HIV portions, and you mix them together so that there's protection against not just a single subtype of HIV, but multiple HIV types. And those vaccine trials are currently ongoing, one in sub-Saharan Africa for women, and another one across multiple countries, including North and South America, for MSM, men who have sex with men, as well as transgender people. So those are really, really promising. The other really promising area in vaccine research is what we're calling passive immunization. So basically antibodies, which we know they're called broadly neutralizing antibodies. That means they basically are capable of neutralizing a large spectrum of different kinds of HIV, which has been one of the problems. You basically take those antibodies, artificial antibodies, and you put into people, kind of like a passive. What the body can't do on its own, you provide to the body these antibodies. And again, these can be given a few weeks apart, 2 months apart, to see whether you can continue to protect people over time. So not a traditional vaccine, but a different way of protecting people in endemic areas or people who are at very high risk for acquiring HIV. So those are a couple of really promising areas. For vaccine researchers, the work never stops. So as Rupert was alluding to, the mRNA vaccine, different platforms of vaccine, many of the ones that are being tried in COVID are actually coming out of the HIV world, where they've been tested and tried in different kind of animal models, in non-human primate models. So there's a lot of lessons learned there.
Well, if the work never stops, I'd better let you get back to it. Dr. Kaushik, Dr. Kaul, it's awfully good of both of you to join us on this World AIDS Day and bring us up to date with what you two and others are working on. Thanks so much.
Thanks very much for doing the program, Stephen.
For the fourth straight year, HIV infection rates climbed in Canada, a trend that's obviously going in the wrong direction. And while HIV, the virus that causes AIDS, is certainly not the death sentence it once was, it remains an urgent and ongoing public health issue. With us for more, and we'll introduce them, as is our custom, from furthest away to closest to our studio, starting in Berks Falls, Ontario, just east of Georgian Bay. There's Laurie Edmiston. She's Executive Director of CATI, that's Canada's source for HIV and Hep C information. In Port Colborne, Ontario, Trevor Stratton, Coordinator with the Canadian Aboriginal AIDS Network. In the west end of the provincial capital, Travis Lanef. He's an HIV/AIDS advocate and a member of the pit crew on season 1 of Canada's Drag Race. And in Scarborough, Ontario, Maureen Owino. She is the director of CAT, C-A-A-T for short, the Committee for Accessible AIDS Treatment. And it's a great pleasure on this significant day on our calendars every year to welcome you all to our program tonight. Laurie, I do want to start with you. As we suggested in the intro, a lot has changed over the past 30 or 40 years as it relates to HIV and AIDS. We all well remember how once upon a time it was a death sentence. It's not anymore. How far have we come?
So we've had tremendous progress. We will talk about where we still have to go. And you led off, Steve, by talking about the fact that the numbers are still going up. That's very disconcerting. But 30 years ago, we didn't have treatments. We have life-saving, not only life-saving treatments, but treatments that now, if someone is diagnosed soon after they become exposed and starts treatment right away, they can live a full and healthy life, which is tremendous.
Travis, you have been quite open about your current HIV positive status since you appeared on that Canada's Drag Race. And I want to know why you think it's so important that you be so open and transparent about your status.
Yeah, well, for me, it's important because the reason I got such good access to care and help was everyone that was open about their HIV status with me personally. So it's kind of a way that I want to pay it forward. And also just, it's so important to have community. There's certain things that you experience, you can only experience as someone with HIV. So it's nice to have someone to look to. So I want to give people access to me.
How long ago did you find out?
I found out 2 years ago on Halloween.
How did you find out?
I went and did a rapid test at the Hassle-Free Clinic. And then I tested positive, and they took my blood to confirm and helped connect me to resources, as well as I said, my friends that were positive helped connect me to resources as well.
Well, that's really what I wanted to find out, because once you found out, one can imagine there's a sense of, oh my God, what do I do now? Were you able to tap into resources right away and get on a good path right away?
Fortunately, yes. I think at first you just have so much to process. So I didn't right away take everything that they were throwing at me. But I was lucky to have a lot of friends that were willing to share their status with me and guide me through this experience. So through it, I was able to access everything. But I know that I'm very privileged in that way, and that's not the case for everyone.
Well, shall we talk to one of those folks? Trevor, when did you find out about your status?
I tested positive way back in 1990, 30 years ago, and I'm 55 now. Wow.
And when you found out in 1990, what was your reaction?
Well, back then, we didn't have antiretroviral treatment. So, getting an HIV diagnosis meant that you'd probably live okay for a little while, and then you get sicker and sicker, and eventually you die. So basically, it was a death sentence. I felt extremely alone. And just like Travis, I looked for others living with HIV to get information. What's all this about? What's it like? How do I live the rest of my life?
Safe to assume that in 1990, you did not think you'd be seeing your 55th birthday?
No, they gave me 2 years to live, actually. I remember that very clearly. And I remember a lot of the drugs back then were so toxic that they were creating side effects in such large doses. Some people would get really sick from the cure, or not the cure, the treatment. It's so much different today. I believe I still have trauma from those days, those demonstrations of desperation. It was a very terrifying time for all of us.
Now, I don't. Actually, we should establish this. I don't know what your relationship status is right now, but I can imagine. How do you deal with the whole issue of whether to tell people about your status as you are trying to embark upon a relationship with someone, or explain all that to us, if you would?
That's a real tough one. I think the best example that I can give is when I took a last-minute trip to Jamaica. I borrowed some money and went down to Jamaica, and I met an American woman who fascinated me. We were snorkeling together and eating the great food and exploring. And on my last night there in Jamaica, we were camping on the beach. This beautiful woman that I was hanging out with said, "Hey, I'd really like you to come and sleep in my tent." tonight down the beach here. And I thought, oh no, what am I going to do? And I decided to do it, to go and sleep with her. But I knew that if things got too passionate, that I would have to disclose it. So it was very scary. As it turned out, we hardly slept. We cuddled and snuggled and kissed all night. And it was the most romantic memory that I probably have. And eventually she came to see me. I mean, we had a long-term relationship after that. She had written her address and phone number on a piece of napkin that I found crumpled up in my pocket. I phoned her and we started talking, and she said, "I'm coming to visit you." And that's when I actually disclosed to her on the phone. And I said, I've been diagnosed. I've been living with HIV for 2 years. And not only that, I haven't been dating women for probably 5 years. I've been with men only. And she came anyway. And she said, I bet you thought I was going to hang up, didn't you? And that was the beginning of a 10-year relationship. And we got married. And through all of it, we wore a condom every time. And she didn't get HIV. When we have more tools now, but back then that's about all we had was condoms.
Safe sex works.
Yes, I used to tell that to kids too. I'd go to schools and tell them that it works, and I'm living proof of it.
I mean, I'm trying to imagine how, when you disclosed your status to her, you must have thought that's probably going to be a deal breaker right there, right?
Yeah, that's right. And I really felt it was necessary to disclose, though. And I had been developing such strong feelings for her. I didn't want to do anything that would hurt her, and I probably would have a hard time living with it if I had passed it on to her. And we had a very strong 10-year relationship. I'd say it's probably the most rewarding and deepest relationship that I've had in my life. Single now and looking. Just in case your audience is looking for an HIV positive partner.
Well, we've never really thought of this program as a dating app, but look at everything's new in 2020, right? Okay, Maureen, let me thank you for all that, Trevor. That was fascinating. Maureen, let's go on to you now. You have been working predominantly with people with HIV for more than a decade, and predominantly with immigrants. And let's just start by having you tell us, what is it that you do?
I'm the director of the Committee for Accessible AIDS Treatment, which is a coalition of organizations that include AIDS service organization, community health centers, people living with HIV, as well as legal clinics, coming together to reduce service access barriers for people living with HIV who are immigrants, refugees, or undocumented. So we do research, we do community development work, we do advocacy, as well as service coordination and capacity building.
How significant is the need right now?
So just listening to Travis and Trevor, as well as Laurie talking about treatment having come this far, it's important to acknowledge that, yes, we are very far, 30 years into HIV. There's a lot of treatment. There's a lot of testing options available that's different from what was there before. But it's important to acknowledge that there's also a lot of health disparities for people with from different populations. There's a lot of marginalized people who still cannot access treatment, still cannot access testing, as well as get linked to care. As Travis said, the most important piece is being linked to services after testing. But still today, there's a lot of people, including Indigenous people, Black people, other racialized populations, people who use substances, as well as sex workers who still cannot access the services as well as the treatment.
Well, that suggests a logical follow-up with Laurie. And I know the numbers for the last 4 years in terms of HIV cases, Laurie, are going up, which is very disconcerting. But is it the case in 2020 in Canada that people are still dying of acquired immune deficiency syndrome?
Yes, unfortunately, it is still the case. And that's primarily people who have not been diagnosed and people who have not been on treatment. So, for example, in BC, a third or a quarter of people who were diagnosed many, many years after they had been exposed, and when their immune system is already seriously compromised, and that's a healthcare access issue. It's a stigma and discrimination issue, and often a population issue, because some populations in Canada have greater barriers to accessing treatment and care. There's about 10,000 people in Canada who are undiagnosed, and not to use any blaming language, but it's largely people who are undiagnosed, who are not on treatment, who continue to transmit HIV. So getting people tested is really, really important. Then they can go on treatment and they can live a full and healthy life.
We should point out that there are governments all over the world, including the Canadian government, that have committed to 3 essential targets in their efforts to end AIDS in this world. And the targets are: they want 90% of people with HIV diagnosed, they want 90% of those diagnosed on treatment, and they want 90% of those on treatment suppressing the virus to undetectable levels. Those are the goals. Maureen, tell us, how close are we to achieving those goals?
I laughed because, so achieving those goals is possible. As Lori said, challenges is for those who get diagnosed late, and late diagnosis creates a lot of challenges. The biggest barrier is even getting people tested, and there's been a lot of challenges with testing because of in some provinces in Canada. There's, for example, in Halifax, they do not have anonymous testing. There's a lot of stigma related to testing and finding out your status. And sometimes there's a lot of barriers to people getting this tested. So for that reason, recently we did, if you're aware, Health Canada approved the first HIV self-test kit in Canada, which is which now is going to increase barrier-free testing. We are hoping that all those people who are living with HIV and are not aware of their status will have access to the testing and be able to access care to get to the 90-90-90.
Trevor, I think the idea was to reach those goals by now, and then to reach eradication of AIDS 10 years from now, by the year 2030. How are we doing, to the best of your knowledge, on that front?
Well, if you look at Canada, we've made a lot of progress, but we're really not there yet. And there's certain groups like Indigenous peoples and people newcomers from other countries who are overrepresented in people who don't know their status, who are not taking the treatment or haven't achieved an undetectable viral load. I think that part of the reason could be around criminalization. So some of the activities, like people who use drugs, drug use is criminalized, and so that causes people to go underground to be able to service their addictions or their drug use, and then people who are living with HIV, we can be criminally charged for non-disclosure of our HIV during a sexual act, even though once we achieve an undetectable viral load, that it is scientifically impossible to pass HIV sexually. So I think, there's the thought of why would I get a test if I don't know I have HIV? Then I can't get arrested. So I wonder, I can't help but wonder if that's preventing people from taking the test, to take the test and then face arrest.
Travis, as an advocate in this field, I want to ask you this. There's a lot of questions about whether or not the healthcare system can walk and chew gum at the same time. And by that I mean we are utterly focused on COVID-19 right now. I mean, so many of the resources of the healthcare system are being marshaled to try to stop the spread, find a vaccine, treat the people who've got it, on and on and on. Is it, in your view, the case that HIV/AIDS is just kind of getting lost in the shuffle as we all focus on COVID?
100%. I think there's a lot of things actually that are kind of just more barriers are getting in the way, even through people reaching out to me on social media. I've had a lot of people needing to navigate, even in Toronto, how to access care or a blood test without a wait because they're trying to find out their levels for a new doctor. So there's just a lot more waiting involved and a lot more barriers. I also heard like people saying like this was the worst pandemic, and it kind of isn't fair and isn't true to all the 39 million people with HIV. So yes, I would agree. I would say that we are struggling to walk and chew gum at the same time.
Now, is it different if you're in Toronto versus the rest of the province?
I think it's 100%. I think it's different if you have a doctor who deals with it regularly. I think it's here we have so many options, but as soon as you get to a smaller community, there's so much fewer options. Right. How are you going to drive so far, plan way ahead, huge lineups, huge wait periods. So it's a lot more work to being well, and every step of the way that there is a barrier, it makes it harder to take that responsibility on.
Laurie, is there another province or another country that's doing it better than we are, and we should look to them as an example?
Every province and territory is significantly different, and as I think your viewers know, the provinces and territories are responsible for healthcare, the delivery of healthcare, and there are certainly some provinces who have really stepped up more than others. In relation to COVID, as well as in relation to HIV, as well as in relation to overdoses, for example. So just one example that is relevant, certainly to HIV and people living with HIV, is that in Vancouver, just last week, the mayor put forward and unanimously got support to decriminalize simple possession of illegal drugs. That's huge. That will help people not be overdosing because of being tucked away in an alleyway or in their home and using alone. There has been a significant increase of overdoses across the country during COVID times, when we are telling people to stay home, when in fact, if you are using drugs, you should not be using alone. So that's one example of a very progressive policy that hopefully the federal government will support, and hopefully other municipalities and provinces and territories will follow suit.
Trevor, I do want to follow up on your work, because you work predominantly with Indigenous communities, and Indigenous communities are disproportionately affected by HIV/AIDS, and I wonder why that would be the case.
Well, it's a very historical reasons. There's something called multi-generational trauma that is a real thing in people's lives, including in my life. Even though I didn't go to residential school, my grandmother did, and many of my family members did, and that's it took away our ability to pass down the Indigenous teachings from grandmother to child or from mother to child. And we had our own health system. We had our own worldviews. We had ways of dealing with trauma and disease and holistic health. And those things were largely taken away through colonization and through the residential school system, and replaced with a system that was not designed for Indigenous peoples. Indigenous peoples were not consulted when the Canadian health system was put together. And I dare say the immigrants that are coming over, it's literally a foreign system that they need to get used to. So that adds up, that trauma, and it would explain why the biggest driver for HIV, getting HIV for Indigenous communities, is injection drug use, which speaks directly to self-medicating and dealing with that multi-generational trauma that many of us carry.
Okay, so let me go to Maureen next. I do remember when AIDS sort of first became a thing of significance in our world, I guess about 35 years ago. We were told that it was so-called intravenous drug users we'd say today, Haitians and members of the gay community. And I wonder if you could tell me, Maureen, why to this day, African, Caribbean, Black communities also seem to be so disproportionately affected by this.
Yes, so thank you. And I think I'll go back to, there's a lot of, as I said, inequities and disparities. Black people are still living in HIV pandemic mode. And now this COVID, which research has shown that also disproportionately affects Black people. So that includes Caribbeans and Africans and other Black people in Canada. This is mostly because of histories of colonization. Of course, there's the issue of anti-Black racism, poverty, determinants of health, the whole spectrum that affects these populations. And more importantly, access to treatment. As much as, and I think going back to Laurie's points, healthcare is a provincial mandate. In Ontario, there is no treatment of free treatment for HIV. People have to buy treatment, either be on disability or have extended insurance or on Trillium. So for those people who fall within the gaps, and I could talk for people who are undocumented or people who are international students, we can talk about temporary workers, they cannot access a lot of those treatments because they're expensive. And this actually becomes a barrier to us getting to those 90-90 goals. So realistically, some of these populations are affected by more inequities, disparities, and a lot of other issues that make them disproportionately impacted by HIV, as well as COVID-19.
Well, let me do a follow-up with you. You mentioned international students. They've been having a tough enough time with COVID, let alone everything else. What kind of phone calls have you been taking over the last few months on that?
There is a lot of phone calls that are being taken, especially for international and specifically for international students who get infected by HIV. And not just over the last few months, over the last few years. We actually undertook a research study to look at the needs of international students who are affected or infected with HIV. And those calls come with accessing treatment. And to your other question, with all resources being put into, a lot of resources are being put into COVID. I believe, and I actually really am grateful that Ontario HIV services have been responding to HIV in very systemic and strategic ways. So there hasn't been so much gaps in terms of access to HIV care, especially in populations that I serve, because a lot of AIDS service organizations have quickly and innovatively created ways in which they could respond to the HIV pandemic or the HIV issues in our communities. So the issues are the same prior to COVID and now, because there's been a lot of responses and really very responsive interventions within the sector, within the HIV sector in Ontario.
Laurie, I want to ask you about PrEP, pre-exposure prophylaxis, which I gather works like birth control. You take a pill every day and you're 99% protected against contracting HIV. Number one, do we have enough access to it? And if we do, why aren't more people taking it?
Excellent question. So it's a miracle drug. It works incredibly effectively. And in fact, what we're seeing in Ontario, and these figures were just released yesterday, there has been for the first time in at least over 10 years, a decrease in the number of new diagnoses in Ontario among males. There also is, there's approximately 9,000 males in Ontario that are taking PrEP. And there's a definite correlation there. If people are taking PrEP, then their chances of getting HIV are virtually nil. So that's great. Unfortunately, it costs a lot of money, as do HIV drugs, and there are there's not restricted access, there's poor access in much of the country, in particular outside of the big cities. And that's partly because of the cost, but it's also partly because of the lack of awareness among people who would be good candidates for PrEP. And those are people who are being exposed to HIV, and also healthcare providers who aren't necessarily up on the new science. So both of those things need to change.
Quick follow-up, Laurie. Is it not on the formulary of the province of Ontario? In other words, if you need it, the Ontario Health Insurance Plan will pay for it. Is that not the case?
It is the case, but our drug access in this country is very complicated. So there are people who may have private drug plans and it may be covered. And then there are people who are on social assistance who can access it through our formularies. Then there are people who are in between that who would need to access the Trillium drug plan, which is for extraordinary drug costs, and they have to pay a deductible, and it's not minor. I believe it's 4% of the household income. So if you, are living with other people, it can be pretty expensive, even if you're just covering the deductible. And again, it's a matter of knowing that it's around and getting a willing doctor to prescribe, because we still do hear about people who are being shamed and discouraged by their doctors to access PrEP.
Sure. Travis, I want to say an expression to you and then have you explain what it means. Undetectable equals untransmittable. What does that mean?
It means people living with HIV on effective medication, taking them properly, can't pass HIV sexually. And actually, I got to be part of a Katie campaign about it with my ex-partner.
And why is it significant to know that?
Because that's how typically this passes. So this helps to fight the stigma, especially like in when it comes to bedroom activities and dating. We're reported by Health Canada as having HIV, so we have that responsibility to have to disclose, depending where you live. I mean, the rules are all different, but it's a useful tool to give people that knowledge to help fight the stigma.
Now, I don't know how old you are, Travis, but you look like a pretty young guy, and you're obviously connected to and a part of Toronto's LGBTQ community. Do you think you get treated differently because of your HIV positive status?
Absolutely. There's so many more, especially because I'm so public about it, there's so many more questions that I probably wouldn't have to deal with, or so many times that I have to educate people that I wouldn't have to otherwise. And then also rejection, I guess. But typically when people reject me, I reject them because I'm happy to know that I probably don't want to sleep with them if they're kind of ignorant. So.
All right, let me finish up on this. We've got a few minutes to go here. And Trevor, you've now lived through the HIV pandemic, which started 35 years or so ago, and now we're into another massive global pandemic, this one for COVID-19. What have you noticed about how the two were handled, either similarly or differently?
Well, when we first started hearing about HIV, I didn't see an all of government effort to respond to HIV. I'm really quite amazed at the political will to fight COVID, where I didn't see that. We had to demonstrate. We had to flip cars over. There were people sending letters to the White House saying, "Throw my dead body on the stairs of the White House when I die," just to make a statement about the lack of care or even the ridicule that existed for people who were contracting HIV. But on the other hand, I see similarities too, in the sense around the guidelines. I didn't follow all of the guidelines. I ended up getting HIV, and around COVID, I'm really careful about what I do because of my first experience. I don't want to get COVID. I don't want to pass COVID on. And, I see a lot of people doing the right thing and being very responsible. But I even see some stigma with COVID where, there's some people who I know who got COVID and they don't want to tell anybody that they got it because for some reason they're thinking there's some stigma around it, and there must be. There absolutely must be. And, this whole thing about I'm strong, I don't need to wear a mask, I'm not afraid of COVID. Well, those are nice words, but the fact is that we're all human beings and we're all susceptible to COVID and HIV. And it's important to listen to the science. And that's where that's where we've had successes around the HIV response is to listen to the science. We had conspiracy theories in the early days of HIV too, that it was a government conspiracy, that they were trying to wipe out LGBT or Black populations from the face of the earth, and 30 years later, that's not nearly as common anymore. We know what causes HIV and we know how to prevent it. We have all the tools for HIV. I'm not sure we have all the tools yet for COVID. We could end HIV right now. It's a matter of the political will, which I see for COVID, but I really don't see it as much for HIV, unfortunately.
Well, I think given what we've been discussing for the last half hour, that people who have watched this or listened to it on podcast will be just a heck of a lot smarter going forward about everything everybody can do. And so I want to thank Lori and Trevor and Travis and Maureen for joining us on the agenda tonight. All the best to all of you, and thanks for your time.
Thank you.
Thank you.
Thank you.
Thank you.
The agenda is always on.
What QAnon does, and any sort of human trafficking conspiracy theories, is really paints a picture of what trafficking looks like. But this picture is not reflective of the reality. And so stories of international child trafficking rings or people being kidnapped off the street, and even though these things do happen, the way trafficking normally looks like, what we're seeing particularly here in Canada, so domestic sex trafficking, is that young people are being trafficked by someone that they know.
Visit our website, tvo.org/theagenda, or our YouTube page at youtube.com/theagenda. It's all there. And that is the agenda for Tuesday, December 1st, 2020. The federal government rolled out its fall economic statement this week, and tomorrow we'll find out what it means for Ontario. Also, we'll get some insight on helping seniors feeling isolated during this pandemic. I'm Steve Paikin. Thanks for watching TVO, for joining us online at tvo.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.